Hello friends. I like to thank IOI's Professor McKelsky, Professor Pavisho for giving me the opportunity to present on this very important topic of infectious scleritis. So what do we know about this? We know that such an entity does exist, but how do we differentiate clinically? How do you manage this patient? So particularly, let's go back to the basics, which previous speakers have covered partly, but I just wanted to kind of highlight where does this infectious scleritis stands in the picture of the red eye. So you can get a red eye because of the conjunctivitis, you can get because of the scleritis or episcleritis, or because of intraocular inflammation, which is iridocyclitis, or also because of acute angle closure glaucoma. So I think most of the doctors, including the residents, probably can differentiate between these entities. But when it comes to the scleritis as such, scleritis can be infective, whereas it can be non-infective scleritis as well. And within the non-infective scleritis, we need to kind of now go about an algorithm, workflow about diagnosing such a form of infective scleritis and how do you manage a form of infectious scleritis. Now, getting into the depth of infectious scleritis, we need to know the significance of it. What are the possible organisms and predisposing factors for causing this? What are the clinical signs or the pearls which we need to know as a clinicians or as a general ophthalmologist or as a uveitis specialist? What are the diagnostic criteria or the things which can be helpful for us and the management? So for this, we can have 5 to 10% of scleritis which are associated with the infections, which might be associated with visual morbidity, particularly because of the delay in the diagnosis and subsequent management. Most of the cases are initially managed as non-infective, and eventually we diagnose those as infective scleritis during the course of the disease. When it comes to the causative organism itself, it can be the direct invasion by the microorganism or can be due to hypersensitivity reaction. It can be due to bacterial infections such as Pseudomonas, tuberculosis, syphilis, leprosy, or nocardia. It can be fungal or viral, anything, whichever can affect the sclera can result into infective scleritis. What is the source of this infective organism? It can come from endogenous source, or it can also be from the exogenous source of infection, particularly after the trauma, or also after the surgeries, which are particularly pterygium or buccal procedure, or there can be impacted foreign body. The causative organisms, as we have discussed, but when it comes to the endogenous infectious scleritis, the organisms can be bacterial, which is staph or Haemophilus influenzae, Treponema pallidum, or Mycobacterium TB, or it can be fungus such as aspergillosis or rhinosporidiosis, or varicella or viruses such as herpes simplex or herpes zoster, or toxocara or toxoplasmosis. Exogenous infections similarly can be staph, pseudomonas, or proteus, and it can be deep bacterial infiltrate with gram-negative organisms. There is a couple of papers, very interesting papers, particularly from Taiwan group, and also my colleague Dr. Mamta has published on this topic of infectious scleritis, looking into the epidemiology of the scleritis. So from this thing, how do you differentiate really from its counterpart, which is a non-infectious scleritis? So this is how a picture of autoimmune scleritis looks like, quite familiar. But when it comes to the infectious scleritis, you can particularly see there is this whitish yellow patch which will seem necrotic. There it is going to be quite crucial to differentiate it from necrotizing scleritis, where the treatment is steroids and immunosuppressive agent, and as against which is infective, which seems to be more granular kind of appearance, more yellowish looking thing. This is again necrotizing scleritis with inflammation, but there is no infection there. But when it comes to some of these pictures, thanks to Mamta for sharing some of these pictures earlier with me, and it can be either due to fungal such as Candida albicans, or it can be due to nocardia. And you can see here the dots or the kind of bulbs or the elevations which are seen there. And this looks like scleral nodules which are pointing towards you, which are deep yellow kind of lesions, or it will be multiple nodules which can be seen there. Sometimes it can be associated with purulent discharge of the pus also. Also at follow-up, you can see how these things can behave. It can also be seen in other patients with the herpes zoster infection, and also in the patients post-surgical, as we have discussed. Here it is quite straightforward, where you can see an infective looking thing which is pointing it out towards this. Again, a picture of fungal scleritis, a picture suggestive of tubercular scleritis. One need to be very careful. Has to be differentiating from the necrotizing scleritis. When it comes to the diagnosis, there is a whole lot of things which goes on here. First of all, very important is to have a high index of suspicion with a relevant history related to infectious scleritis, a source of infection which might help you in clinching the diagnosis. Of course, followed by clinical signs, which are sometimes not so straightforward, followed by biopsy and clinical suspicion. Again, in case if the biopsy is negative, again a repeat biopsy, again a clinical suspicion, again a biopsy. So this is how the cycle of infectious scleritis can move forward. How do we manage such a patient? Very important is to identify the source of the organisms or the causative organisms. They treat the causative organism if you're able to identify with specific antimicrobial therapy with looking at the sensitivity. Also treat the source by finding out and giving systemic treatment. Surgery also can have an important role wherein a debridement and deroofing can help reducing the bulk of the infection. But there will be also important role of supportive therapy in the management of pain and limited role of topical antibiotics. So my dear friend, to sum up, for the infectious scleritis, what are the pearls? It is indeed a diagnostic and therapeutic challenge. One need to have a high index of suspicion before clinching the diagnosis. It can be indolent progressive scleral necrosis with suppuration, especially particularly with the past history of trauma, surgery, or chronic use of topical or oral steroid. Diagnosis is often not straightforward, and it is very difficult to identify the organisms. Exogenous or endogenous, both the sources can be there. Scraping or biopsy might be helpful. Antimicrobial therapy has to be started as early as possible, otherwise we might lose the eye. Surgical debridement can have beneficial role and only need to be considered if it is mandatory. Thank you very much for your patient listening. Appreciate